I now invite Chris Holsinger to give his presentation. Thanks, Chris.
Thank you, Suren. Ladies and gentlemen, good morning. It's a real pleasure to be on this panel. I'd like to thank Dr. Krishnan and Dr. Go for the opportunity to be here. I'm newly at Stanford University after 10 years at a wonderful institution down in Texas, and it's there that through Randy Weber's involvement I was able to learn a little bit about cooperative group trials and the importance and the value and power of randomized prospective clinical trials. And so it's a real pleasure then to talk about prospective work being done on surgery, which is a revolutionary idea in the U.S. multidisciplinary paradigm, to actually be talking about primary surgery trials. And it's a really exciting time because they have two trials focusing on oropharyngeal carcinoma, as beautifully introduced by Professor Donna Lund, and also an HPV negative trial, and I'm going to go into that now. First of all, hello from Stanford. These are my great colleagues there, and we bid you welcome from the West Coast all the way here 3 hours earlier in New York. Just to clarify, I have no financial relationships with Intuitive Surgical or any of the robotic companies today. I do serve as a PI for RTOG 1221. So I grew up at MD Anderson as a head and neck surgeon, and for years it was a very simple equation when we dealt with oropharyngeal cancers. Radiation works, and let's put surgery on the shelf. And as we learned more about the induction regimens, the concurrent regimens, targeted molecular regimens, we saw, although radiation only works as Occam's razor, as a single modality of treatment, we saw that we were very rarely doing that. We would add cisplatin here, carboplatin there, TPF here, multiple induction regimens and targeted therapies. And there was this gradual shift toward treatment intensification. But it was actually Mitch McTay, who's at the RTOG, who actually reviewed some of the best studies out there with radiation plus chemotherapy and found some very interesting things. One, there was a tremendous late toxicity to this approach, which was our standard, of course we're going to treat you with radiation approach. That toxicity was a 43% severe toxicity rate that included a 13% dependence long-term after 2 years, not just immediate after chemo T, but a severe delay of a need for gastrostomy of greater than 2 years. A very high death rate associated with this as well. And so granted, that's Chris Nutting from London reminded me that I'm showing a slide that talked about old-fashioned radiation therapy and that IMRT may be better, but we don't have long-term data about IMRT. And so what this has done is that it's forced us to look a little bit more carefully about the way we treat these patients. And we did that in Houston right before I left. Kate Hutchison and Jan Lewin, who are speech-language pathologists, looked at all patients who were radiated, with or without chemo, who were younger than the age of about 55. And we saw a very similar trend of that long-term toxicity here with a silent rate of aspiration almost 81% in that group. And of course, we had the incredible honor of hearing directly from Michael Douglas and seeing his beautiful wife here in New York talk about the revolution in our epidemiologist disease. We can't do business as usual. And of course, you all know these statistics here. This is an epidemic. These numbers almost used to be flipped 20 years ago. And it's forced us to realize that there's two types of head and neck cancer. This has been beautifully covered by multiple panelists. I'm not going to really dwell on this any further. But this sets the stage with randomized prospective clinical trials advocating for chemoradiation. It really sets the stage for us surgeons to address this. This is a younger population. In the smoking era for HPV negative disease, the average age was in the 60s of our patients. Now it's dropping into the 50s and even lower in this new HPV era. And as a result, because of the long-term toxicity, not because radiation doesn't work, and our ever dwindling age of our populations, we have really lost that clinical equipoise that you have an oropharyngeal cancer, you should be radiated. But we've at the same time had this incredible new field just sort of bubble up out of the grassroots, if you will. And I think while we're talking about robotics today, and I'm certainly going to talk about our robotic trials next, it's important to note that it's not always about the technology. It's actually about you in the audience who are surgeons who know how to operate from the inside out. And whether you use a bovie and a headlight, like Professor Huet did in Paris in 1951, whose work I described in 2005, thank you for that citation, Søren, or you use a laser or some other form. It's about transoral endoscopic head and neck surgery, because that gives us a better view of the tumor, a better view of the margins, and with that view, I hypothesize, and I think these clinical trials I'm going to show you about later will prove that, I believe, that we will do a better job with our patients when we have better instrumentation and better visualization. And so this new era has been born, and with that, some foot soldiers in this new war against cancer. And you see a few of them listed here. I apologize, I've left many of you out. But for a while, this was sort of uncomfortable. You had all these people advocating for the laser. Professor Steiner was pounding his hand on the podium. And it felt a little bit like sort of Mel Gibson in Braveheart, where it was just, it was the surgeons versus the radiation oncologists, and they shouldn't be doing this. This is too toxic. And while that's a nice story, it ultimately is the wrong way to think about this. This is not a war. Although if you look very carefully, I think that soldier there with the red cap, that looks a little bit like Greg Weinstein over there on the other side. But you can download that from Wikipedia and just double check me on that. But it was actually Drew Ridge and David Edelstein, a surgical oncologist from Fox Chase, and Dave from Cleveland Clinic, that wrote a grant. And they said, let's stop thinking about this in terms of a war analogy, and let's do the trials. And so we got together in November of 2011 and ultimately published a consensus statement of all different specialists who realized we've got to address this revolution in transoral endoscopic surgery. Let's stop thinking about this, about focus on the patients and do the trials. And from that, several trials emerged. I'm going to talk and get down in the weeds and talk about some of the details now. 2 trials. One that looked at transoral endoscopic surgery as a way to surgically intensify those patients, the HPV-negative patients that are doing so much worse with chemo-RT. And also, let's look at surgery as a way to de-escalate or de-intensify this knee-jerk reaction for chemoradiotherapy for everyone who's HPV positive, because it works so well. And that's the ECOG trial. So I'm going to take a brief moment to talk a little bit about the cooperative group trials in the United States. These are funded through the NIH, which has the National Cancer Institute, which then funds the CTEP group here, which then provides monies to support the RTAG. It's a bit confusing now because as of March of this year, just 4 or 5 months ago, the RTAG has now become the NRG, so you'll be seeing that a little bit later. And also the Eastern Cooperative Group. This is a group that's focused on medical oncology. Obviously, this group is on radiation therapy. And what was unique about these trials, and I would say it's unprecedented, certainly in our field, but I would say it's unprecedented in other fields. Those 2 cooperative groups who have very different constituencies, and it's very different turf. We have decided through that summit we had in 2011 to use common standards, endpoints, and assessments across these 2 trials. And we've done that for a variety of reasons, because one, we want to be studying in a very similar way, almost like an experiment, this surgery in 2 different populations. That way we have the best chance of getting it right for our patients. But more importantly, we'll have a really unique opportunity to look prospectively at a very large combined population once these studies are done. What are those shared standards and endpoints? Well, all the patients in both trials will both be T1 to T2 oropharyngeal cancer. They will all be N1 to N2B, and of course no patients will have distant metastatic disease. But only patients essentially arising in Wall-Dyer's ring in the tongue base and glossopharyngeal sulcus and the tonsil will be operated on. So we're excluding the soft palate. We're staying away from the posterior oropharyngeal mucosa, largely because the patterns of regional metastasis, especially to the retropharyngeal nodes, are very different. And we're also looking at the shared primary endpoint of progression-free survival across both of those 2 studies. More boldly, we're actually using a shared common technique to look at surgical margins. So we have defined and agreed, I'm going to talk about that in detail later, what exactly that is. We're going to define what a good neck dissection is, And we've shared stopping rules for bleeding, for positive margins, and for other adverse events. And finally, we're sharing common data elements across these two studies so that, again, when these trials are said and done, we'll be able to really look critically at our experience. Bob Ferris is the PI for the ECOG trial. He has already had to leave this meeting, but he sends his regards. I spoke with him last night, and this is his trial design. And I want to draw your attention to the central part of this schema here. It seems a little bit busy, but keep your attention focused here, and I'm going to try and walk you through the schema. First of all, you already know about the eligibility criteria. Every patient on the ECOG trial gets transoral surgery. If you're Mike Keeney or Bruce Hoey, you're going to get a laser. If you're Chris Holsinger or Greg Weinstein or someone who's a roboticist, you're probably going to use TORS, but you're going to have transoral endoscopic head and neck surgical resection plus a neck dissection. And then the trial really begins at the review of the pathologic data that comes out. So if you're pathologically T1 or T2 and N1 with good margins and no adverse features, you're going to be observed. If you have high-risk features, if you have positive margins, extracapsular spread greater than 1 millimeter, which is, I don't think we have time to talk about that today, but this is a very interesting aspect, or greater than 5 nodes, you've got pretty aggressive disease even though you're HPV positive. Postoperatively, you're going to get our standard concurrent regimen. But this is what's really interesting here. In this study, in the standard arm, we're going to treat patients postoperatively with radiation therapy and 60 gray of IMRT. It's the standard post-op dose. And in the control arm, we're going to use radiotherapy that is decreased by 10 gray. And the difference between these groups will be evaluated in terms of progression-free survival from the patients treated in those two groups, as well as a variety of functional outcomes, which I'm going to talk about next. We're assuming that there's going to be an 85% PFS rate in both groups, and we're going to look very critically at some endpoints in function and oncologic outcomes that I'm going to discuss in just a minute. The RTOG trial, or the NRG trial, 1221, is a bit more bold in its design. And while that's been criticized, I think we should be bold in this design because these are the patients that are still dying at an unacceptably low rate compared to those HPV positive patients. And we've not done anything for them really in the last 20 or 30 years. They've not responded to standard chemotherapy regimens. And so why this design is so bold is that we are actually doing, again, exact same eligibility criteria here. We are randomizing these patients up front to treatment. And while that seems a bit revolutionary, if you're an advocate for chemoradiation or if you're a zealot for surgery, that's a pretty radical notion. But I think it takes real equipoise to present this trial to patients because this is the trial that we really need to do to settle this question. Not to decide which is better, surgery or chemoradiation, but decide which patient needs to go into this, into these different treatment arms. But nonetheless, our overall accrual goal is 144 patients, 72 patients per arm. And I'm just going to go quickly through our statistics here in the last couple of minutes. We're going to look at, we hope to improve progression-free survival in this study for the surgical patients by 10%. That power calculation is designed to prove that. Here are the data for who will be treated and how they'll be treated in the chemo-RT arm. Standard stuff, 70 gray plus weekly cisplatin. And then in the surgical arm, when you have either laser or TORS in a neck, we're going to base that adjuvant therapy just like in Bob's trial we'll do. So if you have bad disease, we're going to give post-op chemo-RT. If you have relatively favorable disease, radiation only at a standard 60 gray dose. A few of those patients might be observed if we're somehow wrong about the neck. But nonetheless, this is a very exciting time, and in these two trials, we're going to do something we've never done before. We're going to prospectively credential surgeons. This is going to be done after IRB approval. Surgeons who are participating have to go through kind of a rigorous process. You have to submit 10 cases, a paired op note and path report, and we're going to look very carefully to make sure all those cases are from the oropharynx. And we're going to look very carefully at the quality of the surgery done and the margin status. So the good news is we launched these trials in January. The ECOG was launched in January. The RTOG trial was launched a little bit later in February. And we've got 32 surgeons credentialed and 3 more pending. So this is up and running. And all of us have managed to do this. Here's the list of surgeons. I'll just draw you briefly to the multidisciplinary nature of the group here. We have a general surgeon, or max fac surgeon, as well as a lot of otolaryngologists. RTOG has opened up a bit slower. We've got only 9 centers open now, but we expect several more to come online, and you see them listed there. Here are the standards for neck dissection. We're stipulating that every neck, level 2 through 4, must be done. 20 nodes per side, and we're going to do a rigorous assessment of the functional impact of neck dissection, I think for the first time ever prospectively. Here's what we're doing for margins. 3 millimeter margins are going to be considered clear. We're going to stipulate that all 4 quadrants, medial, lateral, anterior, and posterior, are taken, and that appropriate deep margins are taken. This is going to differ a little bit because in the tongue base, that may be a continuous variable, 0 through 3 millimeters, but in the tonsil, that if it's less than a millimeter of a margin in the superior constrictor, it's still going to be negative. And we're going to examine this as a sort of a binary endpoint based on some, I think, very provocative data that has come out of Korea, looking at the high percentage of patients who have attachment, penetration, and in fact invasion. So we're going to see if these barriers of the superior constrictor actually work or not. We're going to have very defined stopping rules. If in either trial we see a severe catastrophic bleed rate requiring return to the OR greater than 10%, in these trials, they're simply closed. And that was a bit controversial for some of the surgeons. But we're going to do this with patient safety in mind. I believe that we're going to be able to safely do this, but nonetheless, we're defining how we maintain safety as we do this. Finally, we're looking at both patient-reported quality of life outcomes as well as modified barium swallow. Jan Lewin, Kate Hutchison, and others will manage this. And I think what we're going to have is a really exciting result. So just to give you an update here, the ECOG trial has already accrued 22 patients. Again, we're still launching the RTOG negative trial. I'm very proud to say that the first patient accrued on the ECOG trial was actually at Stanford, and he's doing well at 6 months out. So I think so we're off to a good start there. So finally, thank you again for the opportunity to present. I think this HPV positive era has ushered in a whole new era. It's real multidisciplinary care. It's not surgery on the bench. And I think you're going to see some very interesting results over the next several years. Thank you again. If you have any questions about these trials, please email holsinger@stanford.edu. Have a great rest of the day here and safe trip home from New York. Thank you.